The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and welcome to our monthly webinar series hosted by the Office of Integrated Healthcare Research and Policy in the Department of Family Medicine at the University of Colorado School of Medicine. Let me begin by telling you a bit about our sponsors and partners. This webinar series is sponsored by the California Mental Health Services Authority Integrated Behavioral Health Project. Cal Mesa is an organization of county governments working to improve mental health outcomes for individuals, families, and communities. Prevention and early intervention programs implemented by Cal Mesa are funded by counties through voter-approved Proposition 63, the Mental Health Services Act. Prop 63 provides funding and framework needed to expand mental health services to previously underserved populations in all of California's diverse communities. The AHRQ Academy for Integrating Behavioral Health and Primary Care functions as a coordinating center and national resource for people committed to delivering comprehensive integrated health care. The Academy focuses particularly on integrating behavioral health care into primary care practices and promotes a collaborative environment that fosters dialogue among leaders and other stakeholders in integrating behavioral health and primary care. Key Academy casts include the National Integration Academy Council, an expert panel of nationally recognized leaders in integrated care, the Academy web portal and literature repository, where there are over 1,900 citations, and the recently developed lexicon for behavioral health and primary care integration, and much more. You can visit integrationacademy.arc.gov for additional information. The Collaborative Family Healthcare Association is a nonprofit, member-driven collaborative organization in existence since 1995. CFHA promotes comprehensive and cost-effective model of healthcare delivery that integrates mind and body, individual and family, patients, providers, and communities. Advancing Care Together, a project at UC Denver Department of Family Medicine, is a 4-year program aimed to discover practical models to integrate mental health, substance use, and primary care services. The program, funded by the Colorado Health Foundation, has funded 11 demonstration projects that have been organized as a set of diverse comparative case studies and will be linked to supporting cross-project learning. Before I introduce Dr. Patel, I'll go over a few housekeeping items for GoToWebinar. So this is the screen you should be seeing. On the right-hand side, you can listen through your telephone or through your computer. And here you can see your way to submit questions. Just feel free to type and enter questions throughout the webinar, or at the end when we have a question and answer session, you can raise your hand and I will unmute you and you can ask your question over that. So today we are pleased to bring you Dr. Kavita Patel. Dr. Patel is a fellow in the Economic Studies Program and Managing Director for Clinical Transformations and Delivery at the Engelberg Center for Healthcare Reform at the Brookings Institution. Dr. Patel is also a practicing primary care internist at Johns Hopkins Medicine and served in the Obama administration as Director of Policy for the Office of Intergovernmental Health Affairs and Public Engagement in the White House. Dr. Patel was previously the Deputy Staff Director for the Senate Health Committee under the leadership of the late Senator Edward Kennedy. Prior to Washington, Dr. Patel was a clinical instructor at UCLA and associate scientist at the RAND Corporation. Dr. Patel completed a fellowship in the Roberts Wood Johnson Clinical Scholar Program at UCLA and received her medical training at the University of Texas Health Center and Oregon Health and Sciences University, where she served as Chief Resident in Internal Medicine. Today, Dr. Patel will provide an overview of the state of healthcare policy. She will highlight a number of programs in the Affordable Care Act which provide opportunities for more integrated care, such as health homes and the accountable care organizations. Welcome, Dr. Patel. And let me just pull up your presentation.
Great, thank you. And so while you're doing that, Emma, I just wanted to thank everyone for tuning in. And my goal, I know I'm going to stick close to time because I know everybody's time is precious. I'm going to stick close to time and tell you that my goal for today's webinar is hopefully to just give you some new ideas around how, if you're doing work, whether you're in an academic setting, private corporation, public entity, my goal is to make sure that you have the ability and the tools at your disposal to then approach others with whom you might be collaborating on integrated care approaches. So next slide. All right, so I like to start out with this slide, not just because growing up I loved reading Dickens, but I almost feel that those of us who are on this webinar come from living a life that could be embodied by the Dickens Tale of Two Cities. And that's because in my experience in talking about health reform or healthcare policy, the topic of integrated care is almost never really discussed. And I'll tell you, so part of what I want to do is go through things. Next slide. Part of what I'd like to do is kind of go through a number of important elements of healthcare reform, and then in the context of these slides, buried between the words, I'd like to offer some background and context where integration has a great role, where there is more work to do, and where we really need a better unified voice for advocacy, because nobody is talking about integration. All right, so for those of you that are not aware, we've passed health reform, and I think here's what I think people don't think about many times. There was an amazing amount of work that went into the 2,700 plus pages. The Secretary of Health and Human Services, already an important figure in healthcare, has only increased epically in proportion in terms of importance. Her role, he or she in the future, has a role and is mentioned explicitly nearly 3,000 times. There was an amazingly unprecedented amount of authority and discretion given to the Secretary. The reason I mention that is that from a policy standpoint, it's very interesting to basically think about, even though we don't think of the Secretary as making decisions just by herself, it's interesting to think about the impact one can have through the ideas that the Secretary acknowledges are important. And I have not heard Sebelius talk about integration in a more comprehensive way. I know she's talked about, I think one of the challenges for our community, if you count yourselves in this community, is identifying in a very tangible way what integration means when people think about accessing care. And it's not just making sure that people have just behavioral health and primary care, because those can be across town and inaccessible. But then we think about models of care, and I think that's something that as I move forward, I'd like to get you to think about. In terms of mental health, behavioral, you will notice that I go between thinking about behavioral and mental health. I know there's definitely a distinction, but for the purposes of the slides, you'll see that I intermingle these terms, so apologies if you feel strongly in one direction or another. But there are 4 areas where I would say there's some really interesting provisions in health reform. The definition of essential health benefits, and essential health benefits are the benefits that must be covered by the new health insurance exchange plans, or the plans that are in the exchange, or what we now call them the marketplaces. All of these plans must meet the requirements for essential health benefits, and behavioral health services as well as substance use services are included in those essential health benefits. There are also qualified health plans that are part of the Medicaid gap plans, people who don't qualify for Medicaid or outside of the traditional kind of Medicaid population, but these are plans that are offered for low-income people. And there are provisions related to specifically including behavioral and mental health in those plans as well. And then, of course, before health reform, we actually passed very broad mental health parity laws. And then there were also a number of care coordination efforts that I'm going to highlight. Next slide. So the ACA implementation, the other piece that I just wanted to highlight, I'm going to go through a bunch of like pearls that I think it's too hard to go through 2,700 pages in an hour or less. So what I'm going to try to do is highlight areas where I think integration has a key role from a policy standpoint. One of the most recent ones are new requirements for nonprofit hospitals. And I have this section of the law in case that's of interest to anybody, but all nonprofit hospitals are required to perform a community health needs assessment. And within the community health needs assessment, hospitals are expected to define how they reach out and engage with the community and in order to maintain their nonprofit status. Nonprofit hospitals also have to be more clear about financial assistance policies, emergency medical care policies, limits on charges, billing, and collections. And the reason I bring that up in context of integrated care is that if you're working on integrated care in your community and you're doing that in partnership with another provider entity, you may want to think about reaching out, if you haven't already, to the nonprofit hospital and thinking about how the type of care that you're delivering or the kind of care that you're thinking about delivering could benefit the community. And that could actually help meet the needs that nonprofits have for all these different requirements. And the other reason, finances, charges, billing, and collections are not things that a lot of us think of as routine health care, but I can tell you from a practice standpoint, that's basically a lot of what we spend our time dealing with is patients who don't understand their billing, are not able to meet their needs for paying for services. So whether or not you think that's part of integrated care, I would argue it's part of the social determinants that make care better. And because of rules in the Affordable Care Act, nonprofits are definitely looking to partner and are looking for others who have thought about these issues. Next slide. And then we have accountable care organizations. I'll go into some more of that later, but I'm going to assume a lot of you have heard of ACOs. And here again is, I would say, it's a win and a loss for integrated care. So it's a win for integrated care when you read what an ACO must be. Coordination of care, leading to reduced costs. You must have 5,000 Medicare fee-for-service patients, agree to participate in the program for at least 3 years. That sounds great. It's motherhood and apple pie. Some of you may be familiar with health homes and patient-centered medical homes. ACOs are kind of kissing cousins to those entities. What I would say to you is a loss for integrated care, in my mind, is the need for a very explicit focus on some of the issues that people like us who care about behavioral health and mental health in the setting of primary care really matter. And that's not called out specifically. So as an ACO is defined, you don't need to think about incentives that integrate behavioral health or mental health or psychological support. But I will tell you, the ACOs that I've seen that are very successful have done that. So it would be, I think, for anyone, it might be important in the discussion section, for anyone who's interested to try to understand, and ACOs are growing in terms of their presence, and I have some slides in the future, in the next couple of slides that'll show you. But ACOs are only here, they're here to stay. They're only going to grow in size and number. So I do think for the purposes of those of us working in integrated care and clinical settings, it's critical to think about who around you is working in an ACO in your organization or near your organization, and actually having a conversation with them about integrated care. Next slide. And here's where I document how many we have. So, and I pointed out, so the last two approved in Nebraska, I left off the trailer why it matters that they're in Nebraska. These two ACOs, and if any of you are on the phone in Nebraska, it'll be interesting to hear feedback about it. We've already seen a great deal, 220 ACOs approved by Medicare, and now they're only going to be approved once a year. So the next approval cycle will be January of 2000. They'll approve some in January of 2014. But in 2013, in January, two really rural ACOs came together in Nebraska that I think are really interesting because they incorporate aspects of telehealth and telemedicine, which in integrated care is another mainstay for success, being able to take care of patients across the barriers of the clinical setting. And anybody who's in or near Nebraska should definitely, I'm keeping my eye on them because one of the areas they do want to tackle in the Southeast Rural Physicians Alliance is behavioral health. Next slide. The other program that I think is both a win and a loss for integrated care, and I'll just go into I'll try to give you some colorful anecdotes as to how these programs came to be. There's a value-based purchasing program as part of the Affordable Care Act, and the whole point is to pay for quality instead of quantity. Hospitals are taking this very seriously because after a period of time, right now there's a big effort to try to educate hospitals about it, and Medicare is doing a bunch of different measures, pneumonia, heart failure, heart attacks, they're working on measures that are very significant to the inpatient hospital setting, there is conversation for the near future about adding in measures that in the hospital setting that take into account behavioral, substance use, abuse, and mental health issues. But it's really hairy and ugly because the measures in these areas are just not as well defined. So it's a win because it's finally putting attention in the hospital setting on issues that I think could be really important for integrated care. It's a loss because I worry that since our measures are not perfect in this area, or the fact that we don't have many, is an opportunity for people to pass over integrated care for value-based purchasing and to say, too difficult, let's just do it in the things we know. So it's another, again, important area that hospitals are spending a lot of time looking at the details of this program because it affects all of them, and it could mean less money if their quality, if the measures in which they are being measured upon are low compared to average, then they'll actually get less money. Next slide. And then we have another set of programs, and this is I had added the Nebraska hospitals on here too. I'm sorry. I'll tell you a couple of stories about them and why they're very interesting as well. I'm not just personally fascinated by Nebraska. They happen to come through with a slew of really interesting proposals, and if any of you know Nebraska, it's very rural. So the argument that it's hard to do innovation in rural settings has been kind of single-handedly debunked by a lot of the Nebraska provider settings, and so I think it's a fascinating story. The Bundled Payments for Care Improvement Initiative is another huge initiative driving a delivery system change in the country. And here's where I think, again, a win and a loss for integrated care. You can actually propose bundles for certain types of care conditions, everything from cancer to heart failure to orthopedic surgery. I have not seen a proposal that integrates behavioral health, but one could argue that that's coming down the pipe. I think here are the principal challenges in doing something like that from a policy perspective. One, behavioral health is really broad and it's messy, and integrated care is not the pervasive form of care. So how do you promote a system that's not the standard right now, while all the while trying to encourage the people who are doing regular fee-for-service medicine to practice differently? So when you think about what a bundled payment looks like, hospitals are already paid by diagnosis-related groups. They already have kind of their own sort of bundled payment, if you will. What we're trying to do in the bundled payment initiative was to try to encourage hospitals to think broadly beyond just the inpatient hospitalization and to bundle the care 30, 90 days after readmission, and to include in that outpatient services, post-acute services like intermediate care facilities, short-term stay rehab, short-term stay nursing homes. Those were the kinds of people that we wanted to come together. Now you may ask, where does behavioral health fit into that? Nobody really knows. So I do think it's an important, next slide, I do think it's an important care model. I worry a little bit that it's going to be lumped into what is the cost driver right now in healthcare. And if you look at Medicare expenditures, the top 10 conditions can really roughly be kind of categorized as imaging, orthopedics, cardiology, neurology or stroke care, and cancer. And so I think the challenge is understanding from those conditions where integrated care can really have an effect, and how can the policies that have been passed support those models. I bring this up because it's a big Medicaid payments for primary care. Primary care physicians are finally going to get paid Medicare rates for 2013 and 2014, and it's can you go forward one more? I just want to kind of highlight. There we go. Medicaid has been trying to so I'm just going to mention that only because Medicaid physician rates in Medicaid have long been lower. What that means for integrated care means that you're going to have primary care physicians in Medicaid who are actually willing to do more, or not necessarily willing to do more, but who feel at least like a 2-year sigh of relief that they're getting paid what their colleagues taking care of Medicare patients are getting. And there's, I would say, a little bit less of that resistance to try a different model. All right, so these are other areas of integrated care that I've seen carried out in some of the ACA provisions. There's a Partnership for Patients, which is really a hospital engagement network. It's a partnership between CMS and hospitals through basically almost every state hospital association, and about 1,600 hospitals have voluntarily signed up to come together, and they set these goals forward for by the end of this year to actually reduce in 9 HACs. HAC is hospital-acquired condition. 9 hospital-acquired conditions to achieve a 40% reduction in those 9 conditions, and then a 20% reduction in preventable readmissions. I think the opportunity there is that I've seen some hospitals, 1,600 hospitals is a lot of hospitals, but it's an opportunity, again, when partnered with an organization like any of yours that are real kind of champions in integrated care, it's potentially a way for those hospitals to actually have like an effect on care that matters, that's broader than the 9 hospital-acquired conditions and preventable readmissions, because these 9 conditions are just kind of what's been set forward by the partnership, but I think there's great opportunity there. Next slide. And then we get to a number of CMMI initiatives. CMMI is the Center for Medicare and Medicaid Innovation. In the Affordable Care Act, it was actually there wasn't too much direction, except that CMMI would come into existence and would get $10 billion to spend on being innovators in many aspects. And one of the really important aspects of the legislation was that not only did it create the Innovation Center, but it created the Innovation Center to have the power, or the secretary, again, this is another example where the secretary has a lot of power. It gave the secretary an amazing amount of power to take the things that work in the Innovation Center and then to actually turn it into law and to actually change it into policy. And I think from a healthcare policy standpoint, most of what a lot of us who work in both clinical settings or in policy settings complain about is that if you see something that works, that's great, but it's really hard to get the rest of the government to change what they're doing. Well, this is now one vehicle by which if something is working and it has been proven to save money or be better for patients or deliver on integrated care, then we don't have to wait for Congress to pass a law. There's actually a way to implement it broader than just that one program. So it's an amazing opportunity. And there's our webinar is coinciding with a webinar right now that CMMI is doing on the Innovation Challenge. But last year, CMS issued, or sorry, year before last, CMS issued $1 billion, kind of their own version of venture capital, so to speak. And a number of leaders around the country submitted proposals. They had so many proposals, and they were only able to fund a number of those proposals. But for $1 billion, the proposals had to deal with, improving care and improving value, also having some effect on productivity and increasing the workforce, so an effect on the workforce itself, as well as cost savings, some sort of demonstration of cost savings. The Innovation Challenge this round, which is just starting, is on payment reforms. So different models of care and clinical care and how payment models could be applied to that help to improve care in those populations or care in certain settings. I think this is a huge opportunity for integrated care. So I would almost say to you that the Affordable Care Act may not have been written with integrated care in mind, but so many of these programs and policies are what I would say potentiators or enablers of the kind of care that I think we feel, even if we don't really know exactly what integrated care means in our particular setting, we have an idea of what we want it to be, and we also understand what the barriers are. I think the Affordable Care Act programs have been helpful in dealing with some of those barriers. We still have a long way to go, and I kind of highlighted some of those issues. The Comprehensive Primary Care Initiative is a multi-payer primary care initiative. Emma's host institution, Colorado, is a recipient of one of these programs. Pioneer Accountable Care Organizations, these are 32 organizations which were felt to be ready to start ACOs 2 years ago, so well in advance of the rest of the country. That's something out of CMMI. Community-based care transitions initiative, these are looking at models like what Eric Coleman has been doing in Colorado around transitions in care between settings, and it holds a lot of promise. And it's actually a payment program. It's not a grant or a demonstration. It's a payment program. They're paying for these transitions in care in a different way. And then the state innovation models, of which some of your states may be recipients. These are either planning grants or implementation grants to change healthcare at the state level through kind of various incentives for Medicaid as well as for other payers. Next slide. I wanted to touch on the status of health. I felt like I couldn't do a talk without touching on where ACA implementation is. So we have 3 types of health insurance exchanges. We have state-run exchanges, so that you can see the 18 states that have stepped up and said that they would do their own exchanges. California just recently announced last Thursday that they're doing very well with their exchange. They only have 13 plans in their exchange, and they're not only 4, I believe, are statewide. So I think it's still too soon to call things a victory, but it's a good sign that states are trying on their own. 7 states are doing what we call a federal-state partnership, where they want to do their own exchange, but they're just not ready to this year, but they will be at some point. And then 26 are having the feds do it. And you can see that the majority of the country will be covered by a federal exchange. Next slide. And then the Medicaid expansion is also kind of in pieces in different ways. You'll see that supporting it, 27 states, oh, the slide cut off a little. The light blue is supporting, that's 27 states supporting it. The yellow is opposing the Medicaid expansion. And then 7 states in the darker blue are weighing options. Some of these options include potentially letting Medicaid patients buy in the exchange, which is a more expensive option, but it's something that the government has conceded on for some states. So it'll be interesting to see what comes of that discussion in order to try to allow for everyone to expand on the Medicaid program. Next slide. This is the Dartmouth Atlas. I wanted to just, it may or may not be familiar to some of you. I wanted to show this slide, and then I'll show you the next slide. But on this slide, this is the Dartmouth Atlas, hospital referral. This is broken up, the lines or demarcations of hospital referral regions, HRRs. The red shows density in medical spending, meaning the highest end. And you can see some familiar pockets, Miami, Florida, some parts of the Southeast, Los Angeles, California. And then the light, so the yellow is, and the orange goes into, orange is, you know, still expensive, but kind of moderate. And then yellow to light blue, which is kind of the light spending areas. Go to the next slide. And on the next slide, you can see where the concentration of ACOs are. This is actually a combo. These are combinations of public sector ACOs, and I'm sorry the bottom of the slides are getting cut off, but all you need to see are the fact that you can see a concentration in some of the high spending areas. If you look at Florida, there's a ton of ACO activity. In the Southeast, there's a sprinkling of ACO activity. Look at Southern California, tons of ACOs along with Northern California, the Bay Area. And then the Northeast is just a virtual concentration zone of ACO activity. I think what everybody's hoping is that this high density of ACO activity will lead to more dramatic cost savings. What does that mean for integrated care? I don't know. I'll be honest with you. It's not clear what will be the end, kind of result of all this ACO activity. But it goes back to my earlier point that every ACO has care coordination and kind of better care for their patients at the heart of it. It's just a matter of defining that and thinking about where integrated care fits into that. Next slide. Oh. I think there was a slide. Was there a slide? I thought I had. This is fine. I'm not sure if, I think for some reason that Medicaid slide looked like it was merged, but that's all right. We'll just go with this slide. There are also a number of aspects of the Affordable Care Act. I've spent a lot of time talking about delivery systems reforms, but there were a whole host of provisions that had to do with workforce areas. And I do think that this is an important aspect of helping to implement a workforce that's more attuned to integrated care. What I don't know, the unknown answer is, are we actually changing anything about our curricula and training so that more physicians, assistants, nurse practitioners, primary care, graduate nurses are doing things differently or entering into clinical models? And I had talked with a couple of nurse practitioner students who, no surprise to me, said that there is overwhelming pressure in their programs to actually subspecialize. So more and more of them, even though we think, oh, nurse practitioners, they're the mainstay of great primary care, I do think we're having a different conversation about the roles and responsibilities of healthcare workers. Health reform may accelerate that, and it may make it harder, but I'm hoping that programs like these at least create more opportunity so that where people want to train in both primary care and have some additional training, for example, in dealing with patients that might have more behavioral health issues, that they'll find places that have an ability to do that. So the Affordable Care Act actually created more slots, more training programs, and has explicitly focused on establishing more nurse practitioner-led clinics as well as additional primary care training sites. Next slide. HIT, a number of us who spent time before the Affordable Care Act helped to work on the implementation and adoption of electronic health records. It is another area where I think there's a win and a loss for integrated care. If you talk to people who are at places like UW or in clinical settings, or Ben Miller in Colorado, you talk to folks who are experts in this area, and then you identify the challenges. That electronic health record can be a challenge because our electronic health records are generally made for chronic medical conditions that do not account for behavioral health, substance use, substance abuse, and also don't account for children. So they're generally adult-developed kind of electronic health records that are kind of configured for all these other populations or specialties. I think that can present a challenge when trying to truly integrate care, and integrating the kinds of data elements that go along with that care can be a challenge if you've already got a system that's pretty rigid. And as you can see from the slide, there is a huge amount of adoption of electronic health records. So one question I would have for anybody in the webinar is, does anybody have experience with an EMR that takes into account some of the unique elements of integrated care? And it would be great to share some of those lessons if you do have that. Next slide. And there's, go ahead, Emma, and just go through, there's like a bunch of, so this is, and I'm still looking like the slide for some reason on mine is cut off on the bottom, but this is just to show that at the end of the day, meaningful use, which is one of the requirements for physicians to fulfill, individual physicians who want to get paid bonus payments for using their electronic health record have to demonstrate that they're performing, that they're improving access to information and using the electronic health record to help patients get certain elements of information and improve their own care. The goal of meaningful use is to really drive what I think is truly in line with integrated care. Team-based care, case management, registries, patient-centered care coordination, patient engagement, community resources, and then the data from all of this to improve the delivery and outcomes, as well as improve population health, increased access and continuity. We're only in stage 1 meaningful use right now. Stage 2 is in the proposed stage, but people are already working on stage 3. There's been a lot of kind of pushback from different communities, which I think there always will be when you're talking about doing something that's so significant. But from a policy perspective, I think it's important to realize that while we have conversations about integrated care and talk about patient-centered medical homes, ACOs, health homes, remember there's an entire infrastructure backbone, and that's the electronic health record and technology that kind of goes under all of this. And thinking about what the role of that is for these broader pieces is huge. And I think a lot of us don't think of ourselves as tech people, and we think, oh, that's something for tech people. I would argue more of us who care about integrated health need to get involved in those conversations so that we can make sure that they're moving in the direction that we know care needs to go. Next slide. And then I'm going to say, I don't know how many of you on the webinar do research, but I would almost argue that one of the most interesting places for integrated care from a research standpoint could be PCORI, which is the Patient-Centered Outcomes Research Institute, another new provision. There were many new entities created in the Affordable Care Act. This is one of them. And this is an independent nonprofit, quasi-governmental because it's funded in part from some Medicaid funding. And it's a very interesting agency, or I should call it an organization, not an agency. It's not a government agency, but it's really kind of they're using some of the government agencies to outsource for things like reviewing and administering grants. They're using NIH, AHRQ, CMS to some extent. But it has a great opportunity. On the next slide, I talk about some of their research priorities. And it's in line with integrated care. So for those of you doing this kind of research, I think it could be a huge opportunity. Just the next slide when you get a chance. Great. So these are the national priorities that they had proposed. They're actually their national priorities. They had issued these as kind of for comment, but I don't think anybody's argued that these are important. Assessment of prevention, diagnosis, and treatment options, improving healthcare systems, communication and dissemination, and addressing disparities. If integrated care doesn't deal with every single one of those buckets, I don't know what does. So there have already been, on the next slide, there have already been over $150 million awarded up until last year, and a number of these awards have like 2 years of support, where then you could get additional funding along with some travel expenses. So this is just to give you all a sense of the kinds of awards and how much money and what you get and things like that. But for those of you who do research, I would definitely, if you haven't already, look to this organization as a potential source of funding. Next slide. And then I wanted to say, so one of the most common areas in which I think people do not take advantage of, because I don't think anyone knew this, is the Federal Register. So all of the government's proposed rules, whether it be ACOs, health homes, and Medicaid, I have an example up here from 2 years ago on the establishment of exchanges and qualified health plans. This is your chance as John Q. Public to have some input. You can write a one-page letter that says, the government sucks and I think everything should be torn apart, and sign it, and that will be part of the input on these proposed rules. You can have a 100-page thoughtful, comment-by-comment, constructive criticism or breakdown of the proposed rule with some comments for how to improve it, and that can actually change the policies. So the Affordable Care Act was a law. The law directed parts of the government to do things. Then the government has to, through this process of proposed rules, issue guidance or issue notice and get guidance from the public. The public, in my experience, has generally been pretty lacking in awareness, because I don't think this is something that most people even realize they have an opportunity to comment in. And if you ask the follow-up question of does this stuff matter, I would say 100% yes, it does. Especially if you have some knowledge in this area. It is something that when you're on the receiving end in the government, and some of you on the webinar have been on the receiving end of federal input, when you're on the receiving end and you get something from someone who's an expert in an area, that's gold, because you want that feedback. And oftentimes you'll see that exact feedback incorporated into the final rule, which really becomes the way a program is structured. So I would just say, if you Google Federal Register, there's a mailing list so that you can get notices in certain areas. I would say it's one of the most underutilized opportunities for those of us who care about programs in healthcare but don't really fully appreciate how we can have an impact on policy. Next slide. The other thing I just wanted to kind of highlight is where, I mentioned the Affordable Care Act is pretty broad. The ACA has 10 different titles. The bottom 2 got cut off, but you can see how, in terms of the way the dollars are either spent or saved, there are dollars that we had to spend on expanding coverage. That's $504 billion that the government had to find to expand coverage for the exchanges. $434 billion for Medicaid, and then a handful of billions for the other things. But you can see that we had to find a way to save that money, and that's in the third column. So there are a lot of different reforms that went into, as you can see, Medicare took some of the biggest numbers, $450 billion in Medicare savings. A lot of that comes in the form of reduced payments for things like the value-based purchasing program, not paying for readmissions for certain conditions, things like that. So you'll see that the Affordable Care Act, as long and as complicated as it was, on some elements it got down to dollars. How much could we save in the programs so that we could spend it in others? And the president asked very clearly, he said, I need the price tag for health reform to come in under $1 trillion. And the final price tag was about $937 billion. And that was something the president personally wanted to make sure he made good on this promise, that it wouldn't cost, this would not be such an audacious effort that would bankrupt the country without having some ability to pay for it. So it was, so there were a lot of really great ideas that didn't make it into health reform, and some of it had to do with the fact that the money wasn't there. Next slide. And I'm wrapping up. So here's the end, these last couple of slides, this is just to give you a sense. The ACA is a landmark bill, full of a lot of other similar kind of full of smaller kind of landmarks that I don't think people fully appreciate. And this is more of my social activist side. This bill is on par with Social Security, Medicare. Those of us on this webinar, this will be the defining law for our generation, for our lifetime. There were so many smaller achievements that if they were pulled out and separate would have gotten front page news and would have been a huge splash in policy. But because it was in the Affordable Care Act, didn't get as much attention. Patients' Bill of Rights, which I had been working on since I came to DC, coverage of clinical preventive services, Physician Payment Sunshine Act, where relationships between pharmaceutical companies and physicians have more transparency around them. Expansion of Medicaid, which is a very big deal. The Elder Justice Act for abuse to elderly populations. Nobody talks about that. Some progress in biosimilars, expansions of exclusivity in biosimilars, and then the Indian Healthcare Improvement Act. The Indian Health Service constantly had to go through battles for reauthorization and getting their money every 5 years. The Indian Healthcare Improvement Act, as part of the ACA, permanently made the Indian Health Service a permanent entity, so it doesn't have to fight for survival every 5 years. Next slide. And just like every other law, the ACA will be revisited over and over and over again. Social Security has had this. Medicare has been revised almost every year and had some really big revisions, including 2003 with the addition of Part D in Medicare. Medicaid has been the same one. I call this continuous policy improvement. So I did not see health reform as like the start, middle, and end. I saw it as the beginning, and I think that's something for any of you interested in policy. I think it's especially policy related to integrated care. I think this is just the beginning. Next slide, and that should be, this is my next to last slide. So the only thing I'll say is that there is a high level, I've already shown you the political resistance for Medicaid expansions. There are so many threats because we have a divided Congress. But you know what? The truth is that when you explain this to the public, I mean, take the time and explain it, the public actually likes it. They like having their kids under 26 on their insurance. They like not being booted out because of pre-existing conditions. They like not having a lifetime limit. But, you know, I think the devil is in the details, and I think we have to do a better job explaining it. Next slide. So I will be happy to take questions, or Emma, tell me how you want to run this. I know we've only got about 14 minutes, but I'm happy to do whatever you need.
Great. Thanks so much
for having me.
So just a reminder, you can submit questions through the chat feature as well as raising your hand if you have anything, and that the recording of this webinar will be posted on YouTube under our channel, which is CUDFM Policy Channel. So our first question is, do you think the challenges of confidentiality barriers to sharing behavioral health, including substance abuse treatment with physical health providers, can be handled best at the federal level, or must it be delegated to individual states?
So the confidentiality issue, where it intersects with HIPAA. I mean, all these entities are HIPAA-covered entities. So the only problem would be if there's some issue that raises a HIPAA flag, then that would trigger the need for some sort of federal action. I think there may be some provision of HIPAA that might need to be, but I'll be honest with you, I don't think that's the case. Now I'm going to tell you, not a lawyer, so I would say that a lot of it seems to be much more at the local level, and then I would say even more so, it seems to just also be cultural, because anytime I've looked into some of these barriers of information exchange and people invoke privacy or HIPAA issues, when you bring in the lawyers who actually deal with this, they tell you, no, that's not the case. This is because these were HIPAA-covered entities, the exchange of information, albeit somewhat sensitive, does not trigger the need for some sort of federal action. And I think that's the best way to go. I do not think you want revisiting HIPAA unless it's absolutely necessary, because it opens Pandora's box and everybody starts to get defensive about what that looks like.
Okay, are there any other questions? Maybe we'll just wait a minute or two to see if anything else is submitted. All right, Dr. Patel, your next question. How many states have done the 2703 waiver for health homes?
You know, I do not know the exact number offhand. Last I checked, but that was it was a while ago. I thought there were at least a dozen states. And I thought they were also doing some of them in conjunction with their 1155 waivers. So that would be the least of it.
Next, can you speak to Medicaid ACOs? How many states are developing and how is that going?
It's a little more complicated. So I would say almost every state has expressed interest in developing it. Medicaid ACOs are, the confusing part of the Medicaid ACO actually has to do with how to tie the payment. So a big part of Medicare's ACO has to do with this kind of, not complicated, but slightly kind of complicated stepwise quality measure calculation tied to some sort of financial incentive. And it's a lot more complicated to do in Medicaid. One, because the quality measures are different. In Medicaid is such a diverse population, and the quality metrics are not, you can't use the same ones. And then two, thinking about the money in Medicaid, since it funds so many wraparound services, it's just a challenge to think about how the funding would go forward. So where we've seen some successful developments on the Medicaid ACO side, Massachusetts, New Jersey, I know Colorado's been thinking about it in different ways. Obviously, the one that gets the most infamous kind of notoriety is Oregon's CCO. Notice they didn't call it an ACO, but they're using kind of an ACO model for their CCO organization, kind of care coordinated organization framework. So but every state, there was a technical call with CMS where states who are interested could kind of come forward. Every single state came, even the ones that expanded and opposed a Medicaid expansion were present and wanted to think about how they could do something. So I would argue almost every state is kind of in some stage of thinking about it, with, I would say, Oregon kind of being on the other end of what I would say is a very declarative statement about their CCO, ACO model.
Great. We have a question that was submitted on Twitter, and do ACOs really move us far along the payment continuum to support integrated care?
You know, advanced ACOs do. I'll point you to an ACO called AtlanticCare in Atlantic City, New Jersey. And they are great because what they did, I'll just briefly give you this story. AtlanticCare basically started kind of an innovation center within their organization. I think it's brilliant. And the reason they started it before they started an ACO was they wanted to identify high risk. They wanted to identify their hotspotters and figure out a way to take care of them. But they knew it wasn't going to be, one thing I've learned is that you can deliver care, you can't deliver the same care to everybody. I should be doing primary care very differently for about 5% of my population than 95% of them. But my entire workflow and my day and my clinical schedule are structured to treat everybody the same. AtlanticCare basically restructured for a very specific part of their population their care in a different way. And along the way, they learned a bunch of things about themselves and about integrated care and about what they need to do. And they do kind of true integrated care, by the way. And they learned a lot along the way. They then parlayed that to be a Medicare ACO, not just for those hotspotter patients, because that doesn't make a lot of sense, because you want also some healthy patients in your ACO too. But they included some of those hotspotter population patients and the doctors taking care of them. And I would say that those are the kinds of examples where integrated care is kind of truly kind of integrated and the ACO is helpful. What the ACO framework does not do, if you strip away an ACO, it's really a fee-for-service system, because what you do is you take care of people as you normally would, and then at the end of the year, and I'm really oversimplifying it, but I don't have a ton of time, at the end of the year, Medicare looks back and says, hey, Dr. Patel, you actually spent way under your target for this year. We're going to give you some of those savings back. And that's basically what an ACO is. So if you're not doing care differently, you can still be a really high-performing ACO because you save money. But the question is, can you integrate care, save money, and kind of put that under an ACO umbrella? And I've only seen a handful of organizations do it, but the ones that do it are firm believers, and I would say to you, are probably going to be the best examples for us to go out to others and argue that you should integrate care better, and there's a financial model for it, and there's a clinical model for it.
Next question, what will happen if the Affordable Care Act is repealed?
I do not think it will ever be repealed because there are too many parts of it that the private sector and that even Republicans really like, because some of these ideas are actually ideas that came from the Republican Party, including some of the ideas behind health insurance exchanges, believe it or not. So I do not think the entire law will ever be repealed, because to strip away what we've already done, to tell people they can't have health care if they're under 26, to do this, to do that, it just undercuts too much of the fabric of the economy now. It really does. So I do think what will happen is that there are potential programs or offices or some of these new entities that I mentioned. Those are vulnerable, and I think that's more likely than any scenario of the entire law being repealed. Now, I know I live in Washington, D.C., where we talk about repeal all the time. I always ask my friends on the Republican side, I am fine with you talking about repeal, but what would you replace it with? And I would say that that's not a question that many people have an answer to.
And we have a follow-up question to the first one about the 2703 waiver. What can we do to make the case for our state to pursue one?
Oh, a great one. So I actually talked to, I'm from Texas, and even though Texas doesn't want to expand Medicaid, there are a number of people who want to work on like the they want to work on health homes, they want to work on this. I would say if you can find somewhere in state Medicaid, your state Medicaid program, you will find a sympathetic voice who is probably just overworked and overburdened. My suggestion would be that you volunteer. You need to find a coalition of, maybe you need to even kind of partner with a nonprofit foundation in your state who's willing to help kind of subsidize maybe some technical assistance. But to say to the state, we're willing to come with a nonprofit funder for a small amount of money and help you actually put this together. And so I actually don't think many people have a problem with the concept. I think it's that you're seeing states really suffering from a lack of, I have met some of these state Medicaid directors, they have no staff, they have no resources, and they're being asked to do everything. and then they have shiny little, then you this billion-dollar challenge grant distracts them and gets their attention, and they have no desire to work on the health home waiver because it's just too much. So you have to have the state's interest, but I would say that the success factor in getting the first thing started might actually be to see if a nonprofit in the area is willing to put down like $50,000 for some technical assistance to help do the kind of detail finding and fact writing on the waiver, and then that could be something the state doesn't just takes and gives to kind of the federal partners.
Great, and we have time for one more question. Are there mechanisms in place which allow reimbursement for preventative care in the behavioral health area? For example, allowing a behavioral or mental health provider who's working in an integrated care setting to be reimbursed for administering screening measures for depression, anxiety, or substance abuse.
So yes, to the degree I just looked at the US, so yes, as long as the US Preventative Services Task Force, USPSTF, has given that a grade A or B recommendation. And last I checked, because I checked on this for my own practice for depression screening gets a grade A or maybe a B. Some of you can tell me or correct me if I'm wrong. So yes, you will get reimbursement only to the extent to which those preventive services are covered under, acknowledged by the U.S. Preventative Services Task Force. So a lot of aspects of behavioral health prevention outside of depression, I have not seen recommended or getting the grade that the USPSTF requires, but that's your threshold for reimbursement. And I would definitely say, if any of you are in practices that don't have that as part of your, if you have fellow practitioners who don't know that, my best advice is that you actually feel free to contact me, and I can send you the specific language. But I can also direct you, there are many other people in the government and outside of the government who want to help make sure that your practices know this. So yes, you can get reimbursed. It has to be under these. And in fact, just another thing is that in Medicaid tries to even go beyond this, but it's been interesting. There's been less uptake in Medicaid, and I think it's because of awareness. So just FYI, Medicaid actually has some additional reimbursement around prevention that's broader than the Medicare U.S. Preventative Services Task Force guidelines, but it's gone kind of underutilized, and I really think it's because people don't know about it.
Well, we are out of time for today. Thank you so much for joining us, and thanks to Dr. Kavita Patel for the wonderful presentation. And we hope you join our next webinar, which is on in June with Dr. Neil Corson talking about the integration quality measures. Thanks so much.